Hello, everybody. I want to welcome you back to again for the first time. And we are going to have a conversation today with somebody that I've just recently got to know and have been following via Twitter for a while. And we're going to talk about a very important subject. And it may sound, with me speaking, very nebulous, but the work that Dr. Liam Curran does is outstanding. And just give it some time and give a deep listen. I have an empty coffee cup, which is a sin in my world. It's usually full, but I'm doing got some water here. So, Doctor, thank you for your time today. And how are you?
I'm good. Thank you, Darren. And thank you for the invite to talk about my work. I guess maybe I'll just kick in, and give you a little bit of a background. Most listeners are already starting to grasp the accent,
right? Which I love, by the way.
I'm from rural Ireland, a place called County Carlow in the southeast of Ireland, and I think it's kind of the topic that we're talking about, which is fetal alcohol spectrum disorders. It's kind of an unusual one for maybe somebody from Ireland or from rural Ireland coming to talk about, but that's what happened. I was a principal social worker in the UK services in Yorkshire in England, and I had a very, very complex pre-birth risk assessment case. This is going back to the early 90s, and I guess that case, as a principal social worker, it was my first time to really think about child development in the context of pre-birth and what might be happening in the pre-birth stage. Because as social work, we're often trained on what I call the toxic trio. We're trained about the domestic violence, the mental health, the addiction, and how all of those things impact on families and on children. And this was kind of a light bulb moment for me thinking about this. And basically, it took me into Trinity College in Dublin. I returned to Ireland and I went into Trinity College and I did a master's where I asked if drug and alcohol use in pregnancy was a child protection concern. And it was a qualitative study. And I only did it really out of my own curiosity because this pre-birth risk assessment had really kicked off something in my head. And it was a small study, 8 people. But I guess the study, qualitative, it came back with what I termed as a palpable level of concern from the front line around drug and alcohol use and pregnancy, etc. And my study was just, I was just doing it as a master's degree, but next thing I knew, it was taken up by the Society of Knowledge in Ireland. It got part published in a book in Ireland back then, I think, so 2007. And so that started me on a journey because I suppose like I am a social worker and I was a principal social worker, but suddenly I was kind of, I didn't realize that what I had written was potentially controversial. And so
now let's unpack that, for example. So let's start at this. For the listener who might have, or the person watching us, might have a general idea about fetal alcohol spectrum.
Yeah.
If you can explain a little bit to people, because they probably think they know what it is, but they may be way off.
Yeah. So I'm saying, like, coming on from that piece of study that I did in Trinity, then I started to develop more and more. And I suppose as I came along, I realized that alcohol was perhaps the biggest risk factor in the issue of pregnancy and study and how it impacted on child welfare. And that has been written by the Institute of Medicine here in the UK, in the US, where they talk about alcohol being by far the most dangerous of the world. And that creates what was known as fetal alcohol spectrum disorders, that when a woman in pregnancy consumes alcohol, it is a teratogen and it travels through the umbilical cord. It goes into the fetus. Unfortunately, it goes into the bloodstream and it travels to the brain. And alcohol in a fetal stage, I suppose you and I, Darren, we're adults and we have livers and we can process the alcohol quite well.
Mm-hmm. Right.
but the fetus can't, and therefore the alcohol rests longer in the fetus and it rests longer on the brain. And it is where we end up with the concept of what we call fetal alcohol spectrum disorders. It's a range of conditions, of diagnoses that can be given to a child that has experienced prenatal alcohol exposure. And again, I guess say to you that unfortunately today now it's so well researched that it's almost over researched. We have 55 years of research, but still there's a big level of, I don't know if it's ignorance, if it's denial, if it's whatever has happened, that there's still a big barrier in the translation of the fact that alcohol as a teratogen has a direct risk on the fetal development, much more than cocaine or heroin or whatever. Alcohol is more dangerous. And so fetal alcohol spectrum disorders then is a range of conditions. The reason why I'm speaking them as a social worker is that we have overwhelming evidence of how it impacts our child welfare system, because these children, unfortunately, I mentioned there that the alcohol goes to the brain in the fetus. The brain impairments are probably the biggest category of these children. They may have no physical feature. So they may look normal, they may have normal development physically, but they will have an impairment in the brain. And unfortunately, because around 90% of children impacted have no visible feature, they are going through society and very much not being detected, not being seen.
Right.
But unfortunately, the evidence is quite clear. I know, Darren, that you work with the Zachary Horton Foundation. You work a lot with addiction.
Mm-hmm.
You know,
yes,
around 60% of impacted individuals will develop an addiction problem and difficulties. And so I'd have no problem estimating that you are probably dealing with undetected FSD in your addiction services.
Oh, I definitely think so.
Yeah. And I think addiction services, mental health services, juvenile justice, adult justice systems are all picking up these cases. And unfortunately, I feel, Darren, we're picking them up too late. And I guess my work very much over the last number of years in Europe, I was delivering full day trainings to social work, to allied health. Right. I missed out a little bit of my picture there because in 2011, I went to a program with the CDC here in the US in Madison, Wisconsin, and I did a residential program. It was a certified educator of fetal alcohol spectrum disorders. And so with that certification as a certified educator, I delivered CPT training in Ireland, UK, Poland. I did a number of European courses. I did a lot of work in Ireland with foster parents and adoptive parents, etc., where again, these children tend to be most recognized in those services. Did that kind of...
No, it definitely does. There's so much I want to talk about there. Like first, again, from some of the work that I've done and do and observing, I think it's wonderful that somebody with your background can identify this, because you see the practical and unfortunate problems that this manifests in the home life, in the way that they're developing differently, whatever that means. It's you can't recreate this in the lab. You're doing observational understanding, and with your training, you're able to kind of see these things.
Yep.
Now, you know, there was a term in the 70s and the 80s early, and it was very narrow, fetal alcohol syndrome.
Yeah.
And then now there's a spectrum. And unfortunately, I knew children who went through fetal alcohol syndrome. But that was one of these kind of cases where it's obvious with the parents. What you're talking about, I think, it's much more subtle and tougher to find out. And but very important because it's correctable.
Yeah.
But
And it's
go ahead, I'm
correctable,
sorry.
it's preventable in the first
That's the
place.
word I'm looking for. Right.
But it's also certainly that if we could pick these children up earlier or identify them earlier, I think we could slow down that trajectory of these individuals turning up as young adults in the addiction services, in the mental health services, in the homeless services, you know, in the failed education systems. But we're not picking them up. I'm glad you mentioned the 1970s and you mentioned fetal alcohol syndrome. Yes, and I think that this is one of the problems we have today. Fetal alcohol syndrome from early 70s developed clinical guidelines for their diagnostics piece. And as you say, that they were easily identifiable because they were children that had what they call facial dysmorphia. They had certain features that clarified them, whatever. And the ICD-9 and 10, International Classification of Diseases, is able to pick these children up pretty good. I would actually say to you, the children with fetal alcohol syndrome do okay. Why? Because exactly what you said, because society sees and understands them.
Right.
But the reality and what the research is clearly telling us is that 85 to 90% of children born of an alcohol exposed person will have no visible feature.
Right. That's the problem.
And that is the problem. That is the main problem for services. It's a problem for child welfare. It's a problem for our education system, our juvenile justice system, because it's not visible. And I think the problem is exacerbated by the fact that we have an overdeveloped narrative around diagnostics.
Agreed.
And I'm saying to you, Darren, and I'm saying to any listener here, there is a real problem in diagnosing this hidden disability. Yeah. Mm-hmm. The number one piece of information you need to have confirmation of prenatal alcohol exposure. Quite often that's not going to be available. If the child is in the care system, if the child is in the addiction system, you're not going to get that information. And that information wasn't recorded on the prenatal alcohol case, in the midwifery services, etc., in the maternity. They didn't record it. So it's extremely difficult to get that information. And I think the other point to the thing is, like, you know, it's a hidden brain impairment. Now, again, people talk to me and said, oh, an MRI will pick it up. No, I mean, because the brain, Darren, our brains, and you know from the addiction work, they're built up of millions of neurons and synapses connection to whatever. It's a critical piece of hardware that we all have. Mm-hmm. Alcohol as a teratogen, it damages. It may damage 10 neurons. It may damage 15 neurons. It may damage 100 neurons.
Right.
It's very subtle. But equally then, what I'm saying is that just those synapses connections not happening is where these individuals struggle. And I say, you know, a statistic that is researched now for 50 years telling us that 90% of these kids will have mental health difficulties. Mm-hmm. 60% will end up in addiction problems, etc. You know, mental health, addiction, they're interwoven, and you know that
100%. Yes.
Yeah. And so again, it's this high degree of this undetected that, unfortunately, I would say that where society starts to see the neurocognitive, neurobehavioral piece is from 9, 10 onwards. Yeah. Right. Right. And certainly in the early teens and then into the adulthood, that's where but I guess I didn't talk there about doing the PhD. My PhD threw up some really worrying failures in our system, in the child welfare system. It was a grounded theory study, and I was looking specifically. Again, I was qualitative, so I was taking data from the front line. In this case, it was in Ireland. And again, professionals telling me clearly they know there's a problem, clearly they can see it. But I think what professionals universally tell me is that they are bereft of professional education. they're bereft of policy and procedure, or they're bereft of any protocols to work with this. And again, I think because services such as child welfare that has a large percentage, because the prevalence rate studies in child welfare are quite significant. Again, if the child welfare system is purely looking at this and thinking we cannot diagnose all these children, because that's the narrative that's out there, is diagnose, diagnose, diagnose.
Correct.
It's creating this impasse where people are backing away from it because they think there's nothing they can do. I argue that there's a lot we can do, and there's a lot we should be doing to pick these children up. Again, I suppose, like Darren, what I'll say to you, like, it's only like, what, 6-7 months ago that I was sitting here watching the news, and they were talking about Nicholas Cruz, the Parkland school shooter.
Sure.
Now, I don't know if you noticed at the time, but certainly all the I call them the broadsheet newses, the main newses, the CNNs, the blah, blah, blah. They were all running the fact that this kid had F.A.S.D, this kid had fetal alcohol, blah, blah, blah. And I was thinking, oh, this is good. Maybe society will finally waken up.
Right.
Maybe this will be a turning point. But I don't think it just fell to the wayside. Nobody really connected the dots. That now, before they started talking about Nicholas's disability of F.A.S.D, you could just look at the trajectory of that young man and look at his background. It was clearly obvious that the potential was there for him to be carrying this disability. But again, I think, you know, the addiction in the family, the addiction in the people back away from it, you know?
Yeah, I mean, there's just so many variables. It's never clean. Like people want it to be, again, I use the lab analogy, because you have generational behaviors, economics, a lot of other things that come in. So for example, we don't drink a lot. It's 3 generations of my family. This is what we did every day. Well, it might be affecting you. First of all, it might be affecting you. You don't know it yet. It might have been affecting you and imprinted you, and chances are pretty good that it has. Not the same thing, but as C.S. Lewis would say, it's close. I have red-green color blindness. I never knew I had red-green color blindness until I took the test, because you know, it's not like I was walking around going, "Oh, that red light looks blue to me." But you know, it's just, so my thought process is that a lot of these families have this already, and it's just getting worse and worse generationally, and it happens with these kids, and it's a tough thing to understand, and it's a tough thing, but it has to be addressed, because if we truly care about society and care about these kids as individuals, we need to ask ourselves, what's going on here? What are the danger signs? And so we can respond to it. So like, one thing I wanted to ask you is, as a general rule, you've been in different countries, Canada, America, England, Ireland. Do public officials, health officials take this serious, and are they doing enough?
Yeah, I mean, it's a good question. And I guess it comes back to what I'm saying is that, you know, it is dealt with at different levels in different cultures. Let's just look at epidemiologists talking about the rates of alcohol in pregnancy. Now, the US is doing really good here. It's the latest study in 2020 was 13.6 is your national average.
Mm-hmm.
Canada is 10.4, which I think is one of the lowest in the world. Now, that again, that flicks from Prince Edward Island, I think is 5.4, right up to Quebec, I think is 27%. So there's a variation. So, but 10.4 and 13.6. Now you flip across to, unfortunately, my culture and to the UK. My culture has a documented alcohol rate in pregnancy of 82%. And we have another study at 80%. We have another study at 65%. So a recent study put them together and kind of said 75% of alcohol use in pregnancy in Ireland and the UK. So 2 of the highest. But I would say that right across Europe, Europe has been completely asleep on this. and they're asleep at the wheel, and they're paying for it heavily, but they don't know they're paying for it because it is impacting society, it is impacting the health budgets. But it's rather interesting that Europe is asleep on it, because it was 1968 that Paul Le Bon in France really brought forward the first real clinical evidence. And that's why I say 55 years, 1968. The problem with Paul Le Bon's work, it was in French, and it didn't translate very well. Mm-hmm. But it was Jones and Smith in 73 in the Lancet Journal that really then exposed it in our Western English culture. And again, I suppose an interesting statistic from my point of view as a social worker and trying to engage child welfare is that Lancet Journal publication in 73 was 8 children from the child welfare system in Washington who had been labeled as failure to thrive, which is a very common label in our child welfare system, failure to thrive, neglect. But they came to that clinic with the failure to thrive label. They left with the fetal alcohol syndrome label, if you like. Yeah.
Right.
So I'm saying that, yes, I think there's really good work in North America here. Now, how that work translates into actual pragmatic approaches, then I can say it's hit and miss. Yeah. The province of Alberta in Canada probably is the most advanced. It has 4.5 million people. It has 24 multidisciplinary assessment and diagnostic services. Mm-hmm. For a population of 4.5 million, that is a really good resource, because, I know if I was training social workers, then I know clearly that there's a resource that they can access to get help from, et cetera, et cetera. But I come back to, I talk to some social workers. I've talked to social workers in Ireland, and I've talked to social workers in the US in the past month in the context of F.A.S.D. And the social workers in the US, I would say, were 98% concurrent in what they were saying. Mm-hmm. They were really, really struggling. The ones in the US, the young man was 15. He's on his 3rd suicide attempt. He has, I think, 9 diagnoses already. He's on 6 different antipsychotic medications. And only now they're starting to talk about F.A.S.D. And I get frustrated sometimes because social workers contact me for help. And I think they expect me to be kind of Harry Potter with a magic wand that's going to change the whole thing. Again, I kind of say to you, this kid and the ones I'm talking about in Ireland, it's evident from early on. And if we could be picking this up. And so remind me at the end, because I'm publishing a paper later this week where I have a model in it, that I'm wanting child welfare to read that paper and to consider the model, because it is about, the title of the paper is Capturing Invisibility. Yeah. So it's very much focused on this undetectable crowd of children and youth that are carrying this disability, that we can connect with them, we can understand, we can see this disability, but we have got to use a couple of steps to do that.
One of the many reasons I admire the work that you do so much is how you advocate that social workers get trained on identifying this. Yeah. Because again, I'm a big believer that that's how you find these things out, by observing and responding. Talk a little bit about how you came to that conclusion that this is the best or most immediately helpful way.
Yeah, well, I think firstly, I go back again to that CDC qualification back in 2011, where I was qualified as a certified educator, that the CDC at that point acknowledged that there was a gap in our allied health system of understanding F.A.S.D. and fetal alcohol. There was a major gap. I fear that gap hasn't changed much since 2011, but my concern with social work is that, say, here in the US, social work is now mandated in the CAPTA legislation to plan safe care for the child with fetal alcohol. And my concern is that that is not translating into social work education.
Right.
And it should be, because it's a mandated concern. So I'm trying to get social work to kind of say, hang on a minute. Yes, you're asking us to deal with these cases, but you're not giving us training. You're not giving us policy. You're not giving us procedure. Mm-hmm. Oh, and now we're mandated. We have to do this.
Right.
So there's a real issue here in our child welfare system. Again, just throwing some of the statistics, 16.9, 27%, 28%, 29, 31%, 35%, 39%. Those are all prevalence studies of child welfare. Yeah. Now, again, the prevalence of FASDs in our child welfare system is going to be directly related to the alcohol use and pregnancy rates within any one culture as well. Yeah.
Right.
So again, I'm saying the US is 13.9, but you've got various differences within that. And I didn't go and refresh my memory, but the paper is Gosling 2020, and it breaks down all the different rates in the US, in the different states, because some states have high use and some have low.
Without getting without getting too far ahead of my skis here, and I don't want to push this story too quickly. I want it to marinate. Why are you getting pushback on your studies? Because to me, it sounds like it is a societal understanding of helping out long term, and that this has no niche. I mean, anybody and all people, colors, classes, generational, can benefit from this. Why are you getting pushback?
I think, I've got a very public narrative in a sense that certainly my doctoral study is very, very clear in a sense that I'm kind of saying that firstly is that we are a little over the top on this diagnostic mantra, and that we're doing that at the expense of actually being able to intervene and see these children better, because the diagnostic mantra is creating fear. It's creating fear in our child welfare system. It creates fear in social work because they know they're not going to be able to get the $3,000 or the $4,000 for a diagnosis. So they're not even going to try. And my concern is that it stifles our professional approach to the subject, because we're thinking, okay, I can't do that, therefore I can do nothing.
Right. And
I'm saying clearly no. Again, I'm coming back to this paper published this week. I'm hoping social work will read it, because we need to go upstream. I published a book in 2014, can't remember now. It's a co-authored book with foster care called Understanding Fetal Alcohol Spectrum Disorders, a guide for carers, parents and professionals. One of the proudest things I have in that book is the parable of the river. Yeah. And this very much is a public health issue, that where the parable of the river is very real. We need to go upstream and see where this is happening. We need to go upstream and try and prevent this happening. I say the US has done tremendous work on prevention. The Surgeon General, I think from 1986, has had that alcohol warning on labels on drinks, etc., etc. Europe is still pulling its hair out on that one. We still aren't there of having warnings on the alcohol products. So this is a cultural, very big cultural difference. I think again, because I'm cautioning, I guess a good paper that I would reference in this talk would be Bird and Pavlova 2019. Larry Bird and Silvana Pavlova are two long-serving experts of the fetal alcohol world, as I call them. They published a paper in 2019. They estimated that there's 11 million people in the world with some level of fetal alcohol impact. They said that roughly 1% of that 11 million gets a diagnosis. And they acknowledged in the paper it's untenable to try and diagnose 11 million people. Yeah.
Right. Oh, true.
And so they say that a lot of these kids need modest modifications. And that is very much the narrative now that I'm pushing in my public speaking, in my writing, and certainly my doctoral study. I'm pushing that we've got to come back a little bit from this diagnostic mantra, and we've got to start seeing. So the model that I'm putting out in the paper, it's around functional assessments. Darren, the two most written about, the two most acknowledged deficits in these individuals are executive functioning and adaptive functioning. Yeah. We have truckloads of tools in our services that measure adaptive and executive functioning.
Right.
We need to be doing that. We need to be doing these functional assessments and not getting hung up on an FASD diagnosis. Waiting years and years to try and get an FASD diagnosis.
So agree.
While these functional assessments. The other thing, Darren, that is in my model is that the very first step I'm saying is that we should be getting a genetic screen, because FASD is non-genetic. It's not genetic, but the neurobehavioral presentation can look like a lot of neurodisabilities that are genetic.
Right.
And so I recommend, again, that we do a genetic screen, that we look for the panel of intellectual disabilities. The concept there, Darren, is that it should come back as a negative screen if you're on the right track with fetal alcohol. But it could come back with any one of, there's about 50 neurodisabilities that could fit in under the same neuro profile of an FASD situation.
Right.
So
I know you have a paper coming out this week, but I'd like to reference one of your papers from prior to your PhD work. And specifically, you mentioned something that really resonates with me, and that is professionals being trained by those in their profession. Now, I have a feeling, I think I know what that means, because that's my bailiwick as well. If you can explain that, please.
Yeah, well, I think, in that book I mentioned, Understanding, which is available, it actually is sold very well in the US, which I'm very impressed with. But I talk about what Dr. Anne Stresgood here in the US in 1997, I think, with 96, 97, Anne Stresgood said that professionals should be trained by their own profession. Now I go a little bit further and say, yes, but they should also read their own profession. I would say that every profession, psychology, speech language, OT, social work, every profession is published in this discourse. Mm-hmm. And I do think that professionals need to grasp this disability through their own professional lens and through the requirements of their own role and their own profession before they can then effectively work in a multidisciplinary or multi-D approach to children. So that concept of what I will say and clearly say is that for child welfare social workers who are carrying a mandate and statutory role, their education needs to be very clear. Like in my full day training programs, I do ethics, I do law, I do the lifespan, I do the biology of risk, I do the whole gambit, so that social work can feel skilled enough that when they engage with these kids, or when they engage with their allied health colleagues, that they have the confidence to be able to go in and to argue their case for these children. So, sorry.
No, my fault for talking over you. And again, I'm just looking at this from 10,000 feet, but I always, regardless if we're talking about fetal alcohol syndrome, or we're talking about spectrum rather, or we're talking about anything else, I always feel like when it's cloistered, and I'm using that term specifically, when it's just these people have this kind of thought process, being trained by these people, you're not going to get any extemporaneous, any new ideas. You're sealing yourself off, and it starts to just constrict. And that's where I go back to where a social worker comes in, who says, hey, here's what I'm saying here. Here's some other variables. And these people who are in the lab or just in the scholarly tower, they just don't see that. And I deal with that with addiction.
No, and I think Darren, I think certainly, the one thing that I have to compete now on in the field of education, I have to compete against, what I call is awareness education. Yeah.
Right.
And it is literally that this is FSD, this is what it looks like, this is what you have to do.
Right.
That's not helpful, because I think
Agreed.
I'm saying, from a social work perspective, from a psychology perspective, from a speech language perspective, they need to be able to integrate this into their professional remit and into the professional guise. So that's why the training has to be, and again, I suppose I go back to Darren, I'm saying we have 55 years of publications. And I think one of the failures of the system is that our state systems is not engaging with the empirical research. So it's not bringing, researchers are publishing it, but it's not being brought in, it's not being broken down and translated down onto the ground, into the workforce. Now, ADHD, autism, all these other neurodisabilities, that FSD is said to be a lot more prevalent than the two that I've just mentioned, but those will be professionally integrated into the services. But yet we're ignoring 55 years of research. And I kind of think, what is the point of us researching it if we're not going to translate it, if we're not going to disseminate it, if we're not going to kind of break it into pragmatic tasks for professionals to be able to manage? Then I'm kind of thinking we're kind of failing at that kind of crossroad, really.
No, I agree, and unfortunately, the cynical part of me, which I try to put to the side sometimes, is like, well, there's just too much money in alcohol, and there's too much tradition in alcohol, and so we're going to learn to try to live with it, and that scares me. It does, and one other thing, if I can get on my own tangent now for a second, the work that you're talking about and advocating, I think is wonderful. But I think, and we're doing some wonderful things here in America, but I think unless you have a situation where public health care is for everybody, people are not going to go look a little deeper when they have to pay for those kind of services that would be able to identify those things and to say, well, if it's not obvious, I'm sure the kid's okay. I'm sure this is okay. So that kind of leads to my next question, and that's, what can a parent look for?
Yeah, I mean, that is again, that culturally is a challenging question, because again, I'll throw you back to Alberta and say, well, yeah, I know the assessment centers are there. I know I can direct a parent, I can direct a caregiver to them. In my own culture, I wrote in my thesis, I had been training those foster carers and adoptive parents prior to my PhD. I wrote my PhD, they're in the shadows. They're hiding away with this because of stigma, because of fear, because of rejection, that they hide away. Again, I come back to this failed professional integration of the empirical evidence. Yeah.
Right.
Darren, on the 1st of March, which was only last week, Australia introduced FSD into their Medicaid approach. Yeah. So anyone up to the age of 26 now, I think, in Australia that has an FSD will be able to get Medicaid benefits and will be able to, they've also integrated FSD into what I call NIDS, and National Disability Insurance Scheme. And again, children and families can actually access resources and services and funds through those services. Now, I'm actually very, very impressed with Australia, because they've gone on that integration level and on that service level and on that structure level. And so, because Australia, again, I suppose, has come to FSD much later than North America have, because I'm saying it's been kicking around here for the best part of a half a century. Australia have come to it in the last 10 to 15 years, but they've really, I think they've cut through the kind of the craziness, and they've gone into integration piece. So I'm not, if a parent approached me here in the area that I'm in, I'm not sure that I could say to them what service. I can't see those services. And it worries me that if they were integrated into service, because if I tell you that CAPTA amendment in 2010 places social work as plan and safe care, I'm not sure how much the services actually support that amendment into the process, yeah? And how it's integrated. So I think, because certainly I can only speak for what I experienced, and when I experience social workers coming to me for help, they are really throwing their hands in the air and saying, what the hell can we do? We have no education, we have no procedure, we have no policy.
Right.
So, and yet these kids are turning up on social workers' caseloads at quite a significant rate, because Darren, you can know that neurobehavioral, neurocognitive, neurodevelopment, those are the issues that ultimately cause the breakdown in the family unit.
Oh, yes.
It's from 8, 9, 10 onwards that starts to happen, because I suppose I look at child development and I think society is accepting of a child's developmental, how you say, little idiosyncrasies or little weaknesses, and they'll tolerate it up to a point. I think from 6, 7 onwards, the society starts to say, oh no, you should know that now. You should be able to do that. But these neurobehavioral, neurocognitive pieces like impulsivity, Darren, I'd say, interacts with your addiction services quite a lot.
Oh, yes, absolutely.
Because it's the impulsive acts and the lack of fear because of again, the neurodevelopment piece, that they will go into addiction because they have poor understanding of cause and consequence. Yeah. So they cross into addiction quite easy. But unfortunately, they turn up in the juvenile system, way over prevalent in the juvenile justice system. And again, our judicial system is not acknowledging it.
No.
And unfortunately, when they do turn up in high-profile cases like the Nicholas Cruz, the prosecution then sees it as this is just a get-out-of-jail card. You're trying to use something just to throw us, and this is some sort of, it's a permanent brain injury.
Yep.
And yeah, when it gets in a high-profile case like that, people don't want to acknowledge that it could have caused that awful tragedy in Parklands.
Right.
Now, I say again, I read the book. I'm going to give him a shout out here. Jodi Allen Crow, The Fatal Link. Jodi Allen Crow wrote a whole book on this around the link of fetal alcohol and school shootings. And that book, I know, has been translated around the world, but I'm not sure if people connected with it here. And I think, if I remember to say, I think it was 16 of 24 school shootings he assessed, and 16 of them fitted the F.A.S.D profile. And that certainly is coming through. Sorry?
No, I was going to say that absolutely. I'll consider him a personal friend, and I met him through my podcast, whose daughter Meadow was killed in Parkland. I've interviewed him twice. And the name of his book is Why Meadow Died. And you know what? Everybody just wants to blame the gun. But to your point, there's a lot of other things that go into it. That's all I'll say.
Yeah. No, unfortunately, and I think it's a tragic case that happened in Parkland. And I'm not in any way kind of defending.
No, I'm agreeing with you. There's so much more stuff that we in America don't look at.
Yeah.
We don't give credence to, we don't look at. And that's not excuses. And because people seem to, you just make it, like you said, get out of jail free. No, we're looking at reality and we're trying to make sense so it doesn't happen again.
Yeah. But my point again is that if we had integration, if we had this integrated into our services, I think we would be picking up people like Nicholas much earlier.
Oh, 100%.
And we would be preventing these sort of tragedies. But because we keep pushing it under the carpet, we're kind of Again, I'm saying you say there about, but the last cost burden study that was done in 2019 in Canada has it at 10 billion a year cost burden to our public health system, 10 billion a year. Now, when you look at the addiction, the mental health, the juvenile justice, the cost of care, the mental health service, it's not hard to start to see where all of that finances start to add up. And again, I say, are we okay with paying this sort of a cost burden? Because I'm again saying, putting professional education into our system would cost a couple of $100,000 a year to offset a 10 billion a year health cost. Because I do say again, and I certainly wrote about it in my doctoral study, we can't afford those sort of health costs given the world we're in now. And certainly from a European point of view, we have massive work to do on the education of preventing and trying to reduce the levels of alcohol in pregnancy. I say in the US, I do think there's a need to try and get this by the professional neck and bring it into the services better. I think there's a lot of University of Google kind of approaches that are not helpful. And
I agree. Oh,
yeah.
Yes.
And unfortunately the good research, the professional research gets somehow sidelined, and some crazy narratives take center stage. And I think also, I say, Darren, that the good researchers get sidelined.
Okay.
I have a colleague, Dan Dubosky, over in Washington side. He's a mental health social worker. He has written extensively and works extensively on the youth mental health, on mental health and addiction. He's done tremendous work, but he kind of struggles to be heard, or struggles to do, even though he's published widely, et cetera, et cetera. And I guess, like myself, I suppose my pre-PhD publications were very focused on advocacy. My PhD was very focused on child welfare and social work, and it's very different to the earlier stuff.
Right.
But having said that, I feel I've done something for everybody. So I've done some stuff there for the caregivers. That book I mentioned, there's a lot of practical tips in there for how to work with these kids at different age development stages and stuff.
Well, I think this stuff is so important. You mentioned about we can't diagnose everybody, and for all the reasons you just mentioned. Is diagnosis the only option in meeting the needs of children who might be suspected of having fetal alcohol spectrum disorder?
No, and I'm quite clear that, Darren, the research is quite clear that children are impacted from mild to severe. Mm-hmm. Now, the severe is your fetal alcohol syndrome that you mentioned, that you saw back in the 70s. Your mild to moderate levels of FASD, many of those children can be accommodated by what I mentioned in Burden-Popova study about accommodations, yeah? And they can be managed by that thing I talked about functional assessments, about genetic screening, about, those two functional assessments of adaptive and executive functioning themselves, if they're done correctly. If there's a plain English report explaining it to the parent or the caregiver, right, then these children can be understood. And again, what I'm saying, Darren, many of these kids they'll have a dysmaturity. So they may be 15, but functioning more chronologically around 9 or 10. And that's where, again, the society conflicts come in and the breakdowns happen. But again, if you get a functional assessment done, if you can see and understand, yes, this child has a brain impairment and they just need these adaptations. They just need the environment to be tweaked a little bit. And then when we start tweaking the environment, these kids can actually succeed quite well. But
that's a nirvana to me that I hope one day we get to, because there's an old saying in teaching. Yeah, that's what I have my master's degree in. And in the nonprofit work I do, sometimes it's the silent kid who gets along and is polite that unfortunately suffers because they don't raise their hand to say, notice me, I got an issue or I got a problem, or and you see that happen in schools so many times.
Yeah.
I see that in this too, because
Yeah.
it could seem subtle, or people are very busy and they don't notice that this is what's going on, except he should be doing or she should be doing this, but they're really only doing this, and they're very emotional, or they
Yeah.
can't. But
And I'm sure, Darren, at the end of the day, don't get me wrong, I'm sure these type of assessments are happening in our education system, but they're not being connected with the potential etiology of why the child might be. And I think it's important that the etiology of why the behavior is there is important. And I think otherwise, one of my participants in my data talked about we assess, we medicate, and we keep going around in a circle. And ultimately, Darren, again, I talk about social workers contact me, kid 15, X amount of, medications and diagnosis. The kid is so damaged from the missed medications, the missed Again, I'm coming back to functional assessments are not diagnoses.
Right.
They're actually therapeutic interventions. They're actually about just trying to understand the strengths and the weaknesses of an individual. So the model that's in my paper that's coming out, 1 to 5 is all of these type of things to do. Step 6 is diagnosis. My belief is that if you had 100 children on this model, my belief that a good 60 to 70 would fall off the model because they got the modification pieces. Yeah.
Mm-hmm.
And so you might be left with a smaller percentage at the top that, yes, a diagnosis is beneficial.
Right.
But again, I come back to in the cultures, if the disability is not acknowledged and not integrated into disability law, into disability payments, into all of these things, you have to question where is the benefit coming in terms of a diagnosis? Because again, unfortunately, caregivers contact me, they get a diagnosis, and then they go to a service and the door is closed because it says, oh, that's not on our criteria. That's not part of our criteria. Because again, FASD is kind of, it's the elephant in the room of neurodisability. It's out there on the cliff edge. And so many services, because of the lack of training and the lack of integrating it into their service structures, will close the door and say, no, I'm not dealing with that. We don't deal with that. It's not on our criteria. And so I do worry sometimes that I hear caregivers pushing the one diagnosed one thing, and I kind of say, be careful what you wish for. And I do believe that some carers find, because if the culture is not in tune, if the culture is not integrating FSD into its service structure, then your diagnosis might just be a piece of paper. Yeah.
Right.
And that doesn't change.
No.
Coming back to what I'm saying of the model that's in the paper that's coming out, all of those steps actually helps you understand the child.
Right.
And all I'm saying is that let's do these incremental steps. If by the time you get to step 5, you still believe a diagnosis is needed, then fair enough. But I think a lot of kids will actually fall off the steps because they get the correct intervention.
Which is so critical, because get it as early as possible so you can, well, we know that. But
yeah,
before I let you go, I want to ask you really 2 questions. What's next, or where are we right now? And when I say next, the next 2, 3, 4 years in Europe and in America and Canada and Mexico, do you see any subtle change to the positive going the way that you would like? And also, What's next for you?
Yeah. Okay. Well, I suppose on number one, I'm not sure where we're going with it, because I'm a little concerned that we're 55 years in and we're still scratching our heads. And so I am extremely impressed with what Australia has done. And if I was to say to any government minister or anyone else that was listening to this, that what Australia is doing of integrating it into its service structures, that is real progress. Because that is then, I know that under the Medicaid, they're doubling their assessment centers so that the number of assessment centers that a parent can go to have a child assessed to get Medicaid, they're doubling those levels of centers, et cetera, et cetera. That is, I'm a pragmatic social worker. I like to see boots on the ground. I like to see things physically happen. And I'm absolutely bowled over by what they're doing in Australia. And I'm saying they came to this much later than North America. So I think now, really, North America could lead, could learn from what's happening in Australia. And that we need that integration. But I'd also say to state systems and to state services and to the corporate parents of child welfare, please engage with the professionals in the field. People like myself that have been doing this now for 15 years. I kind of, but I'm saying there's more than me. And I'm saying there's social work leaders all around the world that child welfare do well to engage with.
Yeah, and please, people, just Darren's opinion, stay away from those who got the doctorate in Google. Just please. You can get second and third opinions, but please be experts in it. Make sure that somebody who's giving you advice has some substantial evidence behind them of education and of being in a field.
Yeah.
Because
yeah, and I think everyone acknowledges that social media is a risky place these days. I mean, we connected because of my Twitter account. I run a Twitter account. I don't necessarily post great professional pieces on there. I keep it generic. I keep it live. I use it to connect with people, so like this connection. In terms of the second half of your question, I didn't say at the start, I was teaching at Cal State at San Jose University before I moved up here to New England. This year is kind of sabbatical year. I wanted to do the publication. So I published in January, I published the kind of physical data of the front line in Ireland, which called the voice of social work in fetal alcohol. And that was published with the Advances in Dual Diagnosis, which is an English journal. And the next paper, which is capturing invisibility, social workers' responses to F.A.S.D, that's coming out. I'm hopeful this week. It's in typesetting at the moment, so it should be out this week.
Well, good luck with that too.
So I'm on sabbatical. I'm just waiting. I'm hopeful going back. I enjoy teaching. This work is not a job. This is advocacy. It's education. It doesn't pay the bills, unfortunately. So I'm hopefully I'll go back. There's a university in Boston that I've developed links with that I might go in as an adjunct professor there.
Oh, wonderful.
Do adjunct professors and continue to do some of this work on the side. But again, all of my education and stuff is for no cost, So I give away my intellectual capital. So.
Well, you're a good person for doing that.
Well, I'm genuinely saying that Darren, I spent a lot of time in the field. I spent a lot of time with the families. I've co-delivered with a birth mum that had two children of her own. I've co-delivered with an adoptive parent. I've co-delivered with foster parents. I've co-delivered with a medic. So I've done the lot, but I do see the struggle of parents and I do see the struggle of families. I do worry about the stigma, full stop, against birth mums. There's a lot of reasons why a woman might drink in pregnancy, and we've got, there's mental health, there's domestic violence.
Absolutely.
There's a lot of issues, and we shouldn't be stigmatizing women because they have a child.
Thank you for bringing that up, because I mean that goes into a lot of the work that I do. And we have to stop stigmatizing people because
Yeah.
this is just Darren speaking now. I believe that the stigma and the shame kill as many people and delay as many people and delay health as the issue itself.
Yeah.
Because we don't know the reason why, and that's why I'm a big harm reduction advocate too. But let's just see what's going on and fix it, and or try to fix it, try to the best that we can. But we don't know why somebody drinks. We don't know why they're drinking when they're pregnant, and that doesn't mean that we're condoning it, people. You know, it means that we don't know why, but let's try to help them. End of story.
Certainly, as I'm saying, I spent a full day co-delivering with a birth mom, and she was her story of domestic violence was kind of quite tear-jerking almost. And she talked about drinking to kind of numb the pain of the domestic violence, and didn't realize, because she was so isolated, she was so traumatized by the abuse, she didn't have the access to information to understand that she might have been putting the children at risk, But anyway, those are the stories. And I'm saying I have a kind of fairly developed narrative now, because I was out and I've done alongside. I am trying to knock on the door of integration, of saying we've got to start putting this in a more professional ethos, and we got to kind of professionally train our service staff so that they're able to respond to and not throw up the door and say it's not in our criteria.
Right.
But
my hope is that you are successful in that endeavor and that we speak again soon. I truly am passionate about this because, without going into detail, in the 70s, I mean, I'm a child of the 60s, but in the 70s, I became very close to people that went through, fetal alcohol syndrome. So, and then the fact that the spectrum and that it's treatable and preventable sounds like a wonderful way to put a bow on it. It means that there's a path there, and we just need to change paradigms and understand that it could be done. Yeah.
No, I think it can, and I think there are pockets of where it is being done.
Right.
I talked about Alberta is a really good start. I talked about Australia, what they're doing in integration. I've talked about there's different things. There's Irish Hasnoff in Chicago. There's a lot of good work in Chicago. There's some good pockets of work around, but I think we need that integration piece. We need it to become mainstream.
Agreed. So, well, thank you so much, Doctor. I really appreciate your time.
I appreciate Darren, and I thank you for connecting. And I wish you and the Zachary Horton Foundation every great work. I know you're doing great work on the fentanyl crisis and stuff. So
thank you very much. A lot of work.
The best wishes in that.
Be well. Thank you.
God bless. Bye-bye.
Bye now.